Welcome everyone to today's webinar, Electronic Charge Aggregation, the key to streamlining central billing office workflow. On behalf of Becker's Healthcare, thank you for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We'll be happy to help. With that, I'm pleased to introduce our first speaker, Stella Deitch Hendrickson. Stella is a product manager at Patient Keeper focused on revenue integrity applications. Prior to Patient Keeper, Stella managed a team of ITS analysts at Boston Medical Center, the Project Management Office at Beth Israel Deaconess Medical Center, and the Resolute Hospital Billing Implementation Team at Epic Systems. Stella, thank you for being here today. Take it away.
Thank you, Brian, for that introduction. So before we jump into our panel discussion, I do want to do a little bit of an overview about what exactly is a charge aggregator solution. So I'm going to jump over to my slides and kind of do a quick introduction for you, and then we'll go on and introduce our panelists and talk a little bit about their experience.
If you work in a central billing office in a large health system, your current world probably looks something like this. Between EMRs, best-of-breed systems for your specialists, and perhaps even some paper and counter forms, your teams may be logging into a handful of systems every day just to make sure all the revenue is captured and clean. A charge aggregator solution enables CBO staff to do their work in one location, significantly simplifying their day. This tool would have charges and notes from disparate systems loaded into one central location. The coding and billing staff can then work in one simple tool to reconcile and clean charges before sending them to the appropriate billing systems. This is an overview of the workflow with a charge aggregator. Charges come from across your organization through interfaces or direct charge entry. The system would take different file types or HL7 interfaces from numerous systems. Additionally, providers may opt to enter charges directly into the application, which should be available as a web browser, mobile devices, or through EHR integration. Once charges are in the aggregator, several tools are available to the staff working those charges. The system will automatically cross-reference notes to charges to identify any missed revenue opportunities. It will run each of those charges through a robust set of edits to alert for issues such as inappropriate E&M codes for places of service, global periods, or age-appropriate codes. It will also make some automatic corrections, such as adding modifiers and add-on codes. And finally, any charges that require user intervention will be distributed to configurable work lists to match the way your work is managed at your organization. While working the charges, users should have access to review related documentation on the same screen, and users should be able to message providers with additional questions. After being consolidated, reconciled against notes, and edited as needed, charges are batched in the charge aggregator and sent to the downstream billing systems. Charges could be routed to multiple billing systems and can assign multiple CDM codes for charges that are used in different departments. Let's take a closer look at the reconciliation tool in the charge aggregator. A charge note reconciliation tool should consolidate documentation and charges from multiple systems. It can then cross-reference notes to charges to identify missing items. It should be able to find both notes that do not have associated charges and charges that don't have supporting documentation. Through this tool, most clients will see an immediate ROI. At one client, the Patient Keeper Charge Note Reconciliation Report found an average of 5 charges per provider per month. When working the report, users have an option right on the screen to read the note and enter a charge. This tool should be something that can be leveraged by either providers or teams. If a provider would like to run it for him or herself at the end of a shift or at the end of a week to make sure they don't miss revenue, they should have that access to filter to just their own content. Additionally, a practice manager or coder can run the report on behalf of the providers in the entire department. The tool should also be able to handle complex situations. For example, in team-based care, a note might be signed by a resident or nurse practitioner, but a charge is listed under an attending provider. The tool should be able to cross-reference these and only identify situations where there truly is not both a note and a charge for the same visit and patient. Let's dive a little deeper into the types of edits that can be found in a charge aggregator. Edits should fall into a few different categories. There are demographic edits. These check for things such as the appropriate patient's age or gender for the code. Additionally, there can be insurance-based edits to make sure that the right types of codes are chosen for the right registration information. Secondly, there can be code-specific edits. So these are things such as the appropriate use of an E&M in the right place of service. It can also be things such as initial versus subsequent care codes and med-surg versus critical care codes. Also, there should be more complex edits for things such as add-on codes or global periods or secondary diagnosis codes. Finally, there is charge hold functionality. This can range from manually applying hold reasons to route charges to a particular group to review to something that automatically applies a hold for an entire role. For example, a system can be set up to automatically apply a hold for all resident charges to be reviewed. Alternatively, a hold could be manually applied by admins when they want to route a charge for coder review. Finally, let's look at the work queue structure within the charge aggregator. The aggregator should divide up the work to different work lists to match the organizational work structure. For example, if an organization distributes work based on different payers, different billing departments, different types of edits, or different kinds of charges, the system should align the distribution of review to match the work that is done at the organization. Additionally, each work list should have its own set of columns and display items that match the data that is appropriate for the types of issues that the person working that queue will need. For example, a user who's working registration errors might need the insurance information on the screen, whereas someone working different types of errors by department might want to spend more screen real estate on coding information. Users can also take different actions from within the screen. For example, being able to mark a charge as reviewed directly from a list. The idea should be that the user sees everything they need on the screen and can take action on most charges without even needing to open up the code for revision. In addition to providing lists for working charges, the system can also provide lists for visit days requiring charges. Similar to distributing the work based on who reviews different types of charges, the list should also distribute the days that need charges based on different types of workflows. For example, there might be separate lists for outpatient charges that are missing versus inpatient days. And similarly, the items that display on the screen should also align to the kind of information that is necessary for that kind of charge. While entering charges, the user should be able to view the clinical documentation that goes with that day so that they are able to easily enter charges directly from the screen while reviewing the documentation.
So with that, I'd like to transition to our panel discussion, and I'm going to start first by introducing our panelists. So first we have Greg Deneen, who is a project manager and senior systems analyst at Tufts Medical Center. We have Lydia Dutler, who is the Director of Revenue Integrity at Bay State Medical Practices. And we have Elizabeth Lindsay, who's the Director of Revenue Cycle Transition at HCA Parallon. So with that, I'll ask everyone to switch over to their cameras and we can have a conversation about your experience using a charge aggregator. So welcome everyone. And I'm going to start with a very basic question about why a charge aggregator. So in your organizations today, you have a variety of different systems. You have your EMRs, you have your billing systems. What does the charge aggregator, in your case, Patient Keeper, add to your technology toolkit?
This is Elizabeth, and I'd like to go ahead and chime in to start. For us, when the coder is reviewing the charge or performing a full chart abstraction, they have easy access in PK to the note because it's right there associated to the charge. Alternatively, if they attempt to code within our billing system, now they need more than one tool. So that's how we fit PK into our flow.
So I'm going to talk from a little bit higher level perspective of why we needed a charge aggregator at Bay State Health. We had paper charge tickets, and we do hundreds of thousands of charges every year. We had a file room that had boxes and boxes and boxes of charge tickets. And providers would submit charge tickets that were 3-4 months old. They would find them in lab coats. They found them in their car. So this was something that we needed to get our charges in one place where we could look to see our revenue. We could do reporting on our revenue. We knew what we were getting. We can match it up with schedules, and things didn't fall through the cracks anymore. We weren't missing charges. We know when charges are missing within that week, and the practices also know. Patient Keeper gave us a huge amount of reporting capability to look for missing charges. And also now providers, when they're doing their electronic health record, they can easily just click on a button and enter their charge versus finding a paper charge ticket, filling it out, giving it to the staff reviewing it, and it coming via a courier over to the billing office where we had to use data entry clerks to enter all of those. And then it went to a coder, and then that paper charge ticket was filed. It was huge savings for us for staffing. It's a huge satisfier for the providers. The charges go through our charge lag right now is at around 8 days, and it used to be, I forget how bad it was around 7 years ago, but it was huge. And now we're at around 8 days, which is pretty remarkable.
Thank you. So I think you actually touched very well on my next question, which is really how do you ensure that you don't miss revenue using this tool? So I don't know if Greg or Elizabeth, you want to chime in to add to what Lydia kind of mentioned on that front with, those paper charge tickets all over the place and showing up months later.
Yeah, absolutely. I actually agree, and we can relate to everything that Lydia just said here at Tufts Medical Center. We had, prior to Patient Keeper, we had various charge entry reports, and it just became very cumbersome to try to track down, various departments. So going through Patient Keeper, it's kind of an all-in-one avenue, and we're able to use various reports within PK, like the patient charge status or the missing charges report, and we can have, it can get down very granular to the department manager can go through and see at the end of the week how many charges are missing, etc.
I think one of my favorite tools is that charge note reconciliation tool. We did a process with a small group to just kind of pilot and say, how good is it really? And I really don't want to share how many missing charges we found because there were all those notes, there were all those services, and there was all that missing revenue.
Well, I'm glad nobody's missing revenue anymore. That's great. So, okay. So I think number one, we've definitely established that it makes sure that the revenue comes in. How does it help also make sure that it's clean and that you don't have to spend so much time working those denials or those rejected claims because something didn't get done correctly?
I'd like to take this one. I think the most important thing and the best tool that we use is the ability to create our own code edits. So a lot of times the charges would flow down to our two downstream systems, and then we'd have to, fix them down there and chase doctors around and chase charge entry clerks around. Now we're able to do that in Patient Keeper, so we can create any kind of custom code edit in there, stop it right then and there, while either the charge entry or the provider is putting the charge in. So we're able to kind of speed up the whole process by using Patient Keeper.
Yeah. And we also used it, we were able to leverage it in areas where we had less specificity being used for some of our diagnosis codes. We were able to create pickers. An example of that would be in critical care, where they were using pneumonia, not elsewhere specified, when pretty much they knew what kind of a pneumonia it was. So we put the more specified pneumonias at the top of their picker list for pneumonias, and they were able to pick the ones that were more specific to what was going on with the patient. And the same way with HCC coding, which is huge for us, is we were able to move some of those risk adjusting scores that we knew they were doing and move those a little bit higher up for higher visibility. That was awesome for us to be able to do that.
Kind of jumping off on the cleaner claims, I know that that can vary a little bit from the inpatient setting versus the outpatient setting. And I'm hoping you can speak a little bit about how your workflows are different in each of those and how the tool is being applied.
I can take that question. We definitely do a lot of customization between outpatient and inpatient, which are the two very different worlds. We use some functionality within Patient Keeper to be able to drive which charge pickers our users are able to see, so it doesn't become too cumbersome, scrolling through these massive charge lists. So as an inpatient, we're able to see all our inpatient charges, and then from there, we've created custom code edits to fire specifically for inpatient. We do have a lot of crossover of codes that are used in both the inpatient and the outpatient world. And with the customization, we're able to say, when this is an inpatient setting, fire this code edit versus when it's an outpatient setting. So the customization has really been key.
I know some of our providers, one of the things that our inpatient providers, the hospitalist group, really appreciate is the historical data they can see in Patient Keeper, so they can see if someone else has already billed for a service or what's been billed already. They can also look to see if they've missed charges for the inpatient because they're rotating among so many patients. So that's something that's been huge for our inpatient providers, is to be able to see what's already been billed by some of their partners and what's been billed by other people and what they may have missed.
And one other thing that we use heavily, one other thing we use heavily on the inpatient side is the customization of the patient lists. So we've really started to customize down to some doctor's preferences, and we're able to, we have some providers who say we see patients in the ER, so we want to be able to see those same inpatient and ER patients on the same patient list. So I would say the customization of the patient list in PL2 has been extremely helpful, I know, for us here at Tufts.
Yep, that's the same with us too. And one of the other things that we did that I had forgotten about is critical care. We have Patient Keeper set up, so for our intensivist or anyone else billing critical care in the inpatient setting, it allows them to enter their time easily and calculates for them. That was really big because we, especially in the past 8 months with COVID, it's become really important to have that functionality.
Absolutely, same here.
Kind of switching gears a little from those detailed edits and checks and pickers to the kind of bigger picture question. So what does Patient Keeper really do for your organizational strategy? How does this fit into the overall financial picture of the organization from end to end of your revenue cycle? Where do you find that it makes the difference?
Here in our organization, we consider Patient Keeper to be the preferred standard. So when you're trying to standardize across an organization and optimize, we look to Patient Keeper to be that tool that's used for all charge capture in a hospital setting. And therefore, we've launched several initiatives to optimize the tool, take input from our divisions, from our practices, from our providers, from our coders, as well as just work on increasing usage. The more standard we can be, the better we are as an organization, reducing our timely, reducing our charge lag. So that's where we fit PK in.
I think from our perspective, it's identifying missing charges, being able to run reports, We were able to get much more detailed reports on our charge entry, our charge submissions by provider, by division, by billing area. We can slice and dice the information any way we need, and we didn't have that capability before, especially when we were on paper charge tickets. So I think it's that whole piece that's made it so much more clear for us what's actually going on with the charges, and we're not missing it now. We're capturing everything, and we know we're capturing everything. That was huge for us.
You know,
Absolutely, I
Lydia,
agree.
that
And
just
go ahead.
I was going to say, I'm so sorry. That actually just reminded me. Lydia, you mentioned the reporting. One of the things we have implemented is a tracking of changes. Providers want education if they've put in codes and the coder disagrees. We've done two things from an organizational strategy. One is we actually use PK as a conversation tool to be able to say, hey, I think your code needs to be X versus Y. But in addition, if it's not that scenario and we're not having the conversation, we've got reporting now that shows what was the code originally and what did the coder approve so that we can do education versus what used to be a manual tracking. The coder would have to go to a third-party tool, indicate what they changed, why they changed it, and now that's all automated to feed our coding education department.
Absolutely. And one thing I just wanted to touch on with what Lydia said is, I think also Patient Keeper, when I think of it as like a level of security, because before we always had paper tickets, and like Lydia said, I mean, if you lose that paper ticket, it's gone. There's no way of tracking anything. So now when we have, like, for say, an ambulatory clinic visit, we have an electronic record of it. So we expect there to be a charge there. So we have various tools within Patient Keeper to track those and say, we had a visit this day, but there isn't a charge entered, what's going on. So that we've always gone back to Patient Keeper as kind of like the source of truth to say, where is it? Where's the visit?
So kind of building off of that, I'm sure everybody's organizational strategy has changed a little bit in the last year due to COVID-19 and kind of the huge impact that's had on healthcare. So I'm wondering what has changed, or how has the tool really helped supplement any workflows you've had to implement or change, or really just supported whatever organizational strategy you've had to do to deal with COVID?
For us, it was all around implementing telehealth. It was a huge effort to make sure to get it in place. We did a lot of partnership with Patient Keeper teams as well as our divisions to make sure we could put rules in place of, is this an O2, is this an 11, how does the provider want it, what edits are we supposed to do for the payer, all of that. And that was our big focus. It was so critical to capture the telehealth visits occurring in a hospital setting.
I think for us, the biggest thing that we were able to do with Patient Keeper that was huge for us because we had we have 1,400 providers, and we needed to get and managed to get around 780 live on telehealth within about 3 weeks. But the question was, how do we do their charges? How do we get them to enter charges that's easy for them and doesn't weigh the coders down too much? So we were able to create a tab in Patient Keeper called the Telehealth tab. And within that tab, we had things specified for the providers, like Medicare telephone visits. Those had to be billed by time. So we created a picker for Medicare telephone visits. So the provider knew if they were doing a telephone visit, it was a Medicare patient, they had to bill based on time and document, of course. So we had the picker set up for video inpatient, telephone inpatient, video home, video telephone home. So all of those were in there. So it told us what service was being done. It really helped cut the time that the coders needed to spend trying to figure out what charge was done. Of course, we built all of the edits as well, but just having the providers enter their charges in the beginning accurately, or somewhat accurately, even though the carrier guidelines were changing, it seemed like weekly. We were changing our tab almost weekly to meet whatever the carrier requirement was at the time.
Absolutely. I would say here at Tufts, in terms of telehealth, it was obviously for everybody, it was a huge undertaking. And we have 5 EMRs here that we interface charges into PatientKeeper for the ambulatory side. So when telehealth came about, there was various requirements from our professional billing standpoint that we needed to implement in order to get these charges out correctly. And we weren't able to send these new elements from our EMRs, and/or if we were able to, it was going to take a while for them to be able to implement those changes. So we actually used PatientKeeper and built custom logic to take various values sent from the sending applications, and PK built logic for on the inbound side to be able to get the different, field values that we needed in order to get the charges out correctly. And PatientKeeper was actually able to turn that around extremely quickly, and it changed our workflow because we had a manual effort until this was in place that all our charge engine clerks had to do in order to get those charges out correctly.
That's awesome, and very glad we were able to support that, because I think COVID's definitely made everybody's lives a lot more challenging in the last year, obviously for numerous reasons, but glad we could help with this little piece of it. So I want to shift a little bit to talking about sort of from different perspectives within your teams. So I think I'll start with on the coders and billers side. How has this really helped make their workflow more efficient?
The coders have really appreciated PatientKeeper and having all of their charges electronically. They're assigned a holding bin. Let's say for cardiology, they go in and all of their charges are in one place versus getting paper charge tickets, trying to read providers' handwriting, which could be a really big challenge. Now it's all in there. It's very clean. The providers can put notes in PatientKeeper for them if they want to clarify something that they're working on. So it's been huge for them. It's easier to go in and see what you have and know how many charges you have in there and how to manage your workflow.
And Lydia, that actually makes me think of one of the efficiencies we've gained is cross coverage, because there's nothing worse than logging into work and not having a lot of work, or probably actually what's much worse is logging in and having too much. So we've gained efficiency kind of from that work list that you're talking about and having the cross coverage. And I think that has really helped the coders be more efficient. They can stay streamlined in their normal lane. And then if we have something getting out of balance, we have folks that can jump in and help them get back in alignment.
Right, and that's exactly what that's what's made it so easy with using PatientKeeper is at a glance, you can see which area is out of control and has too many charges and where you need to redistribute your coding team to help out.
Absolutely. I think one of the most important for us, at least, aspects of PatientKeeper is the ability for various workflows. So we have some providers who will come in and they'll code their own surgeries and then they'll save them as a draft. And then we'll have our coders come in after, verify everything. Sometimes they need to add additional diagnosis codes, or they might say, you did this procedure, but I think it also qualifies for this. And it's also another way of us tracking supplies. So for some of our departments, the provider is just required to enter in the surgery that was performed. And then the coder will come in after the fact and they'll add in, all right, you did this, so we need to add in supply X, Y, and Z. So just that flexibility of being able to save as a draft or to hold a charge for a review. PatientKeeper has the ability to create your own custom hold for reviews. So we've started to do that. And we'll, if we have a provider entering a surgery, we can have him put it on a surgical review or a coding review. So just that flexibility is what we really look to with PatientKeeper.
So kind of building off of what Greg just said about helping the providers out as well, actually, how has the tool helped providers having something like this sort of managing their charge entry processes?
Well, I'd like to chime in on this one. We specifically have trained some of our rounding providers to use the ChargeNet reconciliation. It can be very frustrating for them that their patient list may not be 100% accurate because they're not associated to that patient in some way within the medical record or within that registration. But again, because there's tools that are showing all the notes that don't have charges, they can quickly make sure before they leave that all of their visits are completed. It shows if it's draft or signed. and then they can make sure that charge is submitted. And this has really helped us with not having that missing revenue we've talked about.
That's great. And then I think kind of building off of that for your management team as well, are they using similar reports or other reporting tools to also help them keep an eye on, the revenue and the flow of the charges through the system?
I know in our organization, we specifically train all of our managers and directors how to run their own reports in Patient Keeper and how to run the reports that are pertinent to their specific areas. And many of them do run their own reports, sometimes daily, sometimes weekly, sometimes not at all, but that's not that often. The expectation is that they should be able to go in to see how their providers are doing. Are they missing charges? Is there a charge lag? How are the coders doing? Hopefully they don't find much of that, but we do train every new manager or director that comes in has Patient Keeper report running training so they can keep up with their own charges. And some providers have wanted that training as well. So that's been big. They never had insight into that. And that was one of the biggest complaints our providers had is, I want to know what's going on with my charges. I feel like they're going into a black hole and I don't know what's being done, or if they're sitting on someone's desk for, a month before they're being put through. I'm not sure about that. Now there's no question that your charges are in and they've been processed, and they can run reports to find that out.
Lydia, I think most
Absolutely.
of our audience is incredibly jealous that you have providers who want to know what's going on with their charges.
Oh, definitely. There are some that absolutely want to know exactly what's going on with them.
That's great. And I think, Greg, you
Absolutely.
want to...
Yeah, and just to touch on that, I think also the ability to kind of track via an audit in Patient Keeper has been really helpful, because for us, charge lag, everybody's focused on that. Upper management, that's all they care about. They want to know, where is the claim? Why isn't it open door yet? And then there's a lot of pointing fingers back and forth. Like I said, we have providers who enter in their surgical charges, and then they get moved over to the coder. The coder has their amount of time to, code the visit, process it out, and then we have management staff who then export all the charges out of Patient Keeper. So sometimes if the charge lag increases, we run audits through Patient Keeper and run reports to see, whose fault really was it? Was it the provider, 10 days after the date of service entered in the charge, or was it the coding team was behind and the provider's piece was done? So the ability to audit that and see exactly when charges were entered in, when they were created, when they were reviewed, when they were sent out is awesome. We really, upper management is always saying, we have this high dollar claim. Can you show us, the status of it in Patient Keeper? When was it entered? When was it coded? When was it exported? So that we rely on that very heavily here.
We do as well.
So how have your staff responded? What do you hear from your staff about the tool? Do they like working in it? Are they happy to have this tool? Do they have struggles? How do they feel about it?
For us here, we hear a lot of positives, specifically around the hold for review concept. Greg mentioned that earlier as well. It answers that question of why is my charge not in my billing system? You can specifically see why it's on hold for some reason, as well as we have ownership behind it. If it's on hold, then we're looking to the practice and the provider to assist us. Is the documentation unsigned? Is it missing? Is there something missing within the documentation that I cannot complete this coding? And I think that is where we see a lot of positive response, because it's very clear, kind of to Greg's point, who's to blame for where that charge is right now.
I think that and ease of use. I don't know how familiar you guys are, but we have so many different EMRs, and so many of the times we've asked them, hey, can you create this charge picker, or we have this new modifier that we need to be used. Can you add it onto these CPT code XYZ? And the overwhelming answer usually is no, or it's going to take a lot of time. So everyone always just thinks of Patient Keeper as we can get it done quickly, we can customize things. So it makes my department look really good, and because we have that flexibility in Patient Keeper to accommodate all these things. So I would say that users definitely like and appreciate Patient Keeper because it's very easy. It's easy on the eyes. It's easy to, shift through all the different screens. And
it's probably the reporting capability out of Patient Keeper is probably the primary reason why in our outpatient setting, the facility side asked if they could put their charges in through Patient Keeper because they couldn't get the same detail of reporting that they can get out of Patient Keeper from their own billing system. They have had a different billing system, so they requested that we to put their CDMs into Patient Keeper so they could do their billing from Patient Keeper just for that reporting and that level of detail in reporting.
Thank you all for your comments here today, and I'm going to hand it off to our host, Brian, who's going to open up to the greater audience for more questions.
Thank you so much, Stella, Greg, Lydia, and Elizabeth for that wonderful conversation. We will now begin today's audience question and answer session. You can submit any questions you have by typing them into the Q&A chat box on your webinar console. So let's go ahead and dive right in. The first attendee question we'll take here, the attendee asks, so how has Patient Keeper impacted your resident workflow?
Hey, Brian, this is Stella. I'm going to ask that Lydia speak to that one. I think that's a good one for Bay State has a lot of resident workflows.
Yeah, we do have a lot of resident workflows, and particularly in our health centers where we have a huge volume of residents, we wanted to be able to give them the experience of learning how to bill for services, not just take care of the patients and document the services. So what happens is the resident sees the patient, they document the service, send that note to the preceptor for them to sign, then they launch Patient Keeper, and they go in and choose the appropriate CPT code for the visit, and then the preceptor goes in after discussing the case with the resident. They go in and review the charge. If they agree with it, they click on submit to the coder, and it sends it to the coder for then it's processed that way. If they want to make changes, they can make changes at that time. Or they can also wait until the end of the day and run a report for a work list and identify all of the charges that were submitted by the resident and approve those en masse. They can review them, they can see which CPT code was chosen, and they can review those and submit those to the coder. It works really, really well for us in that area.
Wonderful. Thank you, Lydia. The next question we'll take, the attendee asks, for the charge to note reconciliation process, how are you handling situations when an NP or other team member writes a note?
Elizabeth, do you want to speak to that one? I think HC's had a lot of experience with that.
Absolutely. I'm probably the charge note reconciliation champion queen. In our environment, we utilize two views in the charge note reconciliation. The first is matching on provider. It's our default standard view. I mentioned it earlier with our rounding providers. The second view is to match it on department, where you can remove any note from view that another provider in the same department has already charged for that day. Also very helpful again in rounding. But in addition, what I really like is Patient Keeper logic understands how to match when notes have two signatures, specifically such for mid-levels, and tagging off of what Lydia said, same for our residents.
Thank you, Elizabeth. The next question we'll jump to is, do you do technical billing, and how are you handling it with the Charge Aggregator?
So I know Tufts is definitely doing technical billing as well as Bay State, so maybe Greg could go first on that one, and then Lydia can chime in as well.
Sure, absolutely. This is Greg. So as I mentioned earlier, here at Tufts, we about 95% of our ambulatory billing comes on a charge interface from one of our various EMRs. So from there, we've built a ton of logic and preprocessors in PK to say, if this procedure or this CPT code is received, then bill X, Y, and Z on the technical side. One thing that we find extremely useful is we've basically taken some of the work away from the provider. in terms of having to enter in various technical supplies. So to give for instance, in our urology department, we have providers who will perform an in-office procedure, like say a cystoscopy. And from there, we've built logic in PK to say, all right, if we receive a cystoscopy CPT code from our EMR, then we know we also need to bill supplies X, Y, and Z. So it just gives us a lot of flexibility to bill those hospital supplies, as well as we have various departments who are not live on a EMR charge interface. So in PK, we have extensive charge pickers built that have macros that will bill both a professional and a hospital fee. So Patient Keeper has definitely been very instrumental in helping us streamline and automate processes.
To add to that, one of the pieces that we found really helpful is in areas where we have AV billing, we've built the facility side charging the CDM into our system. And let's say the MAs are doing an immunization, they can enter it themselves. And the way we have it set up is we're not dependent on the facility side to complete before we submit our charges. Even though we use each other's information for diagnosis coding and some procedure coding, it's not dependent on each other. We can release our charge first or release our charge last. So we're never holding each other up.
Thank you both for weighing in there. We're going to jump right to the next question. We've had a ton of great questions roll in. We've got a very engaged group on the line. So the next question then is, what do you do when a provider doesn't know what to charge? Is there a process for asking a coder?
So Elizabeth, do you want to speak to HCA's process on that one?
Absolutely. We offer what we call tracking codes. You can think of those as a please chart abstract CPT. These custom codes indicate if it was a procedure, diagnostic, E&M visit, or an assistant surgeon, thus helping the coder down the road know what note to look for. Our providers are encouraged to use tracker codes when they do not know or are unable to locate a specific or accurate code assignment. And providers who are comfortable and prefer to select their own codes are fully encouraged to do so, but this is not an all or nothing decision. A provider who generally picks their own codes could choose on a particular visit to do a tracking code because maybe it was a more complicated procedure and they're really just unsure what to do. So again, we use those tracking codes as a please chart abstract for me.
Great, and then we'll jump right next to the next question here. So the attendee asked, is PK primarily utilized for provider services, versus ancillary services?
So I think I can actually answer that one myself. So I will say that the majority of our customers are using it for provider services. That is definitely the most common use of it. But many are also using it for ancillary. So it's pretty much everyone does the provider services, but several also do the ancillary. We don't have a lot that are ancillary only, but there are definitely folks importing, radiation oncology, pathology, regular radiology in lab. I think there's also sort of that gray area, as Lydia had spoken to, with like vaccines in clinics where it's, more that provider office experience, but we are capturing a medication charge in that case. So I think we'll have lots of clients doing ancillary in addition to provider services, but just about everyone is also doing provider services.
Thank you, Stella. Some helpful clarifications there. And then the next question we'll take is, what EHR are your organizations using? If Epic, how well does this tool integrate with Epic and Resolute PB and Resolute HB?
So I'm going to ask Greg to go first because I know that Tufts has quite a few EHRs, and then I can chime in a little on the Epic piece as well.
Absolutely. To name a few, we interface in from eClinicalWorks, iMedicWare, Modernizing Medicine, Merge, and Logician.
And then I can also sort of chime in that HCA is using Meditech for most of their divisions, but there is one division on Cerner, and then Bay State is Cerner. And then sort of from my previous experience, so I actually used to work in a hospital with Epic. They'll pretty much take imports into Resolute Hospital, Resolute HB and PB from other systems, as long as it's kind of in that standard import format, which we can definitely produce. So it's really no different for us than going to any other billing system. I know the general experience is that Epic likes to be a fully Epic shop, but I think in practice, a lot of Epic customers are in fact still using a lot of ancillary systems, and they do tend to, go Epic, but still can use PK, and we've integrated with numerous Epic customers.
Thank you both for tackling that one. And the next question then is, I am new to the PK technology. Can this be used for providers that do not have an EMR?
So we can actually speak to that one as well. So it can be. I think we heard several folks on this call actually talk about how they used to have those paper billing sheet processes. So they did happen to have an EMR for the clinical documentation, but the charge was coming off of a paper encounter form, which is essentially what you would experience if you had no EMR, is you'd still just be directly entering charges into PK. The only downside would be that charge to note reconciliation process that looks at all your notes and checks against your charges, unless you were manually scanning all your notes directly into PK, you wouldn't be able to reconcile against notes on paper. We just, if they're not in some system, we can't get them into PK unless you put them directly into PK, which is an option. You can put them directly into PK. Additionally, we haven't really talked about this today because it's not really the scope of this particular session, but PK itself does have a sort of a clinical component. So if you're looking for sort of a note writing tool, that is an option as well. But I'm not going to go too far into that one because it's a separate thing. I think you'd still be able to use it for a lot of your charge reconciliation, and you could scan the notes in if you wanted to off of a piece of paper.
Thank you, Stella. The next question we'll take is, the attendee says, I apologize if you mentioned this already, but are you able to track charge entry / coder productivity in the tool?
Elizabeth, do you want to kind of speak to some of the HCA productivity reporting?
Absolutely. What I love about Patient Keeper is that every action is saved as part of an audit trail, which includes the user that performed that action as well as the timestamps. And some key timestamps for us are the date of service, the create date of the charge, when it was last reviewed and each time it was reviewed, and the authorized date. Authorized is when you say this charge is approved to go to the billing system. We have all of that information as part of our enterprise data warehouse. And then coding leadership has developed numerous reports at both inventory so they can keep track of flow, do I have the coders in the right place, as well as productivity reporting. Because again, I can see each time that coder has touched that charge. That doesn't give you everything you're looking for, just please reach out. Thank you.
Thank you, Elizabeth. And then the next question, the attendee asks, what has the biller experience been with PK? Positive, negative?
So I'm going to actually ask each panelist to sort of comment on that. So Lydia, do you want to go first?
Sure. The coders absolutely love it. Absolutely love it for a couple of reasons. One thing, they're not dealing with paper charge tickets with handwriting that may or may not be legible. The other thing they like from a workflow perspective is if they're working in what we call holding bins, let's say cardiology that has all of the charges, if they've already worked the charge but it's being pended, needing more information, they have a bin they can go in and it shows them immediately what they need to work on or what they need to follow up on. It's all there. It's all automated. It's really quick. They love it. They're able to do their job much quicker and more efficiently.
Thank you. Elizabeth, you want to go next?
Well, it's really hard to say more than what Lydia already said, so I'll try. Again, positive. I think one of the key items is the note is right there. The struggle prior to PK would be similar to what she was saying. I have this piece of paper, and that's great, but the medical record is still sitting over in some other system. So having Patient Keeper sit on top of Meditech, which is what we primarily use, means the note is right there. Makes it much easier for the coders to do their work. And I think that audit trail is the second thing that is a really positive experience. Thank you.
So I guess Greg is going to be really sad to go last if you guys have kind of said it all already, but I'm going to still let him chime in if he has anything to add.
Yeah, absolutely. I know personally from a provider's perspective that everybody really seems to like the flexibility of Patient Keeper. As I kind of touched on earlier with the custom patient lists, we're really able to, sit down with a provider one-on-one and, alter their patient list and get it down to exactly what they want to see. I'd like to see, my inpatients here, or, I go to various satellite locations. So that customization, I know, is what it always comes back to. And also just the ability that Patient Keeper in general has of flexibility. We come up with a lot of crazy ideas here, and we're usually able to articulate them over, and we kind of turn those ideas into working processes. So I think the flexibility is the key component for us.
Thank you all for jumping in on that one. It will roll right to the next question. So the attendee asks, how much time on average are coders still spending per record to finish each record to prepare for billing? How much time did Patient Keeper save on average per record?
I'm not totally sure if people will know those numbers off the top of their head, but I'm going to ask Lydia, do you happen to know? I know you tend to know a lot of numbers about what's going on at Bay State. So I figured I'd ask if you happen to know that one.
We've been on Patient Keeper so long, I'm not sure that I remember. We did track that the first few years. I mean, I know that our lag time has dropped several days. I think the number is around 4 to 5 days. Because if you think, we had paper charge tickets that were being transported by couriers, and that would take 2 to 3 days to get in and be processed. We'd have to log everything. So from that perspective, it's immediate. The provider enters their charge, and it shows up in the queue for the coder immediately. I think part of the question, too, was how much time per record are they using to finish. Of course, it depends on whether it's a surgery or an office visit. But the fact that the note is available right there, they don't have to go separately into Cerner to look up the note. They click on the link. They can pull up the note and verify diagnosis codes or look at procedure notes or operative notes, has made it much, much quicker for them to process charges. And we actually reduced staff initially because of the efficiencies we gained. We've added staff subsequently due to volume increases, but we definitely saw some reduction in staff and improvement in our lag days.
Thank you for that. It's a good question. I think if you're looking for some more specific metrics, we can also follow up with that. And thank you, Lydia, for kind of the numbers you are able to remember.
Yeah, definitely appreciate that, Lydia. We've got time for maybe a couple more questions, so we'll get right to it. The attendee asks, we have a facility EMR and a provider EMR. Can this work with both? We currently get charges on paper, but all documentation is in the two EMRs.
So that sounds very similar to what Tufts has. So I'm going to let Greg speak to that one, please.
Yep, definitely. We have, as previously mentioned, we have 5 different EMRs that we interface in, and some of them are strictly for professional billing, some of them are strictly for facility billing. So we do have the ability via those preprocessors to determine what we want to go out, what we want to process. We also have various reference lists set up because on some of our departments through those EMRs, they decided not to participate for one reason or another. So I would say that flexibility to be able to decide what goes and what doesn't go is definitely there. And yeah.
Thank you for tackling, Greg. And the next question is the attendee asks, is PK limited to the EHRs aforementioned?
So I think I'm going to answer this one myself. So there are no limitations on PK as far as which EMRs can be integrated. We do have an integrations team whose kind of sole purpose is to work with everything. I think interoperability is one of the pillars of PK's sort of business strategy. So we have a team who will pretty much figure out how to make the files work with whatever systems are there. And so far, we haven't experienced one that we couldn't make work. Obviously, some EMRs provide better data than others, and there needs to sometimes be additional custom logic added to fill in gaps. But I think that's actually one of the benefits, that we can usually manage to put something in to support that and to handle whatever data a given system can produce. Pretty much the only limitation would be if an EMR or EHR just doesn't extract data at all. So if it extracts into an Excel spreadsheet, a CSV, an HL7 interface, we'll work with it. The only limitation is if there's a system that literally doesn't allow you to take data out, which we have yet to encounter so far. But that would be the only limitation.
This is Greg. I definitely agree with that that statement from Stella. We've sent some data from our EMRs, like very bare bones, and we've been able to make the interfaces work.
Excellent. Well, thank you, Greg. Thank you, Stella, and thank you, everyone. I think that is a good place to sort of wrap up this conversation. So, Stella, I want to throw it back to you for any final thoughts.
Yeah, so first of all, I want to thank our panelists for participating today, and then also the audience, definitely thank you for joining and for these great questions. I think we talked about a lot of different topics today, so I just want to maybe recap a couple of the key themes around why charge aggregation. So really the big kind of concepts here are that it's about standardizing and centralizing coder and biller work, making sure that they are all in one system and to the extent that you want to, doing one workflow. And then the other big thing is really about matching notes to charges, having the tools to reconcile the note to the charge, to review the note while doing the charge, really being able to drive your charge capture off your documentation. And then the final thing is the flexibility it gives providers, because it is, not about where the charge is captured, but about where it's worked. It really creates a lot of opportunity to work the charge capture piece around whatever your doctors are comfortable with or your other staff who are entering charges. I think that's everything I have for today. Again, thank you everyone for your participation.
And that concludes today's webinar. Again, I want to thank Stella, Greg, Lydia, and Elizabeth for a great conversation, and Patient Keeper for sponsoring today's webinar. To learn more about the content presented today, please feel free to reach out to Stella Ditch at the email address on your screen. And don't forget to fill out our post-webinar survey. Thank you for joining us, and we hope to have you join us for future webinars.